Thank you, Matt, and thank you for inviting me to present on depression and distress in Peyronie's disease, the impact on men and couples. Okay, these are my disclosures. And what I plan to do this morning is to share with you sort of a survey of the major papers on depression, distress, and relationship problems in Peyronie's disease. So let's start off with Smith's paper, who recruited 245 subjects from his practice and asked them to complete a Peyronie's disease questionnaire that included 2 yes-no questions on emotional and relationship problems. Smith found that 81% of patients reported having emotional problems, and 54% of patients reported experiencing relationship problems. When they did a further statistical analysis, they recognized that penile shortening and relationship problems predicted emotional problems, and the inability to have intercourse and emotional problems predicted relationship problems. The limitation of this study, however, is that the 2 questions were yes or no questions, so there was no ability to look at nuance other than yes or no. This next study was done by 2 academic institutions. Dr. Hellstrom was one of the authors, and Chris Nelson was one of the authors, so it was at both in Tulane and at Memorial Sloan Kettering. They recruited 92 subjects, and at baseline, what the real strength of this study was that they looked at people prospectively for up to 18 months. And they gave something called the CESD, which is a 20-item validated questionnaire. And they noticed that 47% of the subjects they recruited scored above the recommended cutoff score. And if you looked within that sample, 26% and 21% respectively scored in the moderate and severe range. Being single and reporting penile shortening predicted depression. And just to show you this, if you look at, this is the prospective follow-up on the CESD. And if you look at the bottom, the orange bars orange rows going across, you can take a look at depression. What's important to note here that these authors found that while depression starts off at about 35% based on the CESD, if you look at it over the course of 18 months, that it not only it doesn't go away, it gets worse. So therefore you would say, oh, patients will adapt to the situation. What you recognize is they're not adapting, they're still struggling. So a group of us, many, many years ago, it seems like now, were asked to put together and develop a Peyronie's disease questionnaire. And what we did with this was we did focus groups of men, 7 focus groups throughout the United States. There were 28 men with Peyronie's disease and 36 men without Peyronie's disease. And we found that these men were most concerned with the following things, which then evolved into the questionnaire that people use these days. So their concerns with physical appearance, and they would say even looking at it is unpleasant. Their sexual self-image, I'm not a man. Sexual function and performance, it's less satisfying. And I think what I find in my clinical practice, and I can't speak to your clinical practice, is that the avoidance of sexuality is the main thing. So therefore, it becomes a problem not just for the man, but for the couple if they're in a relationship. Then there's social stigmatization and isolation and difficulty talking with this or telling a healthcare professional about the injury. So, emotional distress. So, Rose Hartzell at the San Diego Institute of Sexual Medicine, Irwin's Place, wrote a very nice paper in Sexual Medicine, and she talked about treatment targets. So Rose talked about depression, anger, body image dysmorphobia, feelings of shame and inadequacy, isolation, rejection, and the avoidance again of intimacy. So this was sort of what she said we ought to be looking at as treatment targets. And if you look here at the middle row, couples therapy, these are her suggestions. The expansion of the couple's definition of intimacy and sex, the exploration of non-intercourse activities or being more creative, improved communication, determination of what sexual satisfaction means to the partner, the development of alternative methods for achieving sexual satisfaction. So in conclusion, you can see that there's a great deal of depression and relationship distress in this population. Clearly, what we need here is a collaborative effort between urology and mental health. And generally, we don't see that. Neither specialty alone is able to provide the comprehensive care that's needed. The incidence of depression and relationship problems is strikingly high. So I want to tell you about something that you may not know about, that the American Psychological Association developed through their state networks, something called the Psychology Interjurisdictional Compact, or what we call PsyPact. So that means if you're a PsyPact psychologist, you're allowed now to see patients in different states. Previously, I live in Florida now, I couldn't see patients outside of where I'm licensed, which was Florida and Ohio. But now I can see patients in up to 40 states. This has to be approved by the state's legislature, signed by the governor, and so on. But if you're a PsyPact certified psychologist, what I always hear from you all, my friends and colleagues, is I can't find a psychologist in my state or close by to see my patients. What having a PsyPact person allows you to refer to one of us who can see your patients through telehealth, if that's acceptable. That doesn't take care of the issue of insurance or finance, but it certainly takes care of finding somebody who may be able to talk to your patient and support them while you treat them. So far, PsyPact exists in 40 out of the 52 states, which isn't bad, and the other states are working on getting it through the legislature. So thank you for your attention, and I'll stop here.